All right, good morning and welcome to our first session of the eHealth 2022 conference. My name is Carina Andreatta from St. Joseph's Healthcare Hamilton. I'm also an eHealth 2022 ambassador. Really excited to get things started with you all this morning. We're going to kick off today with 5 fast-paced e-poster presentations. If we have time for questions at the end of each presentation, we will address those at the end. Please type your questions and comments in the Zoom chat box. You are also encouraged to connect with speakers after the session via the virtual event platform, so please make sure you do so. First up for today, we have Eva Serhal, Senior Director, Virtual Mental Health and Outreach, Center for Addiction and Mental Health. Eva, I'll pass things over to you now.
Thank you. Well, thanks so much, Carina, and I'm really pleased to be here. So I know this we only have 5 minutes, so there is an in-depth description of this study that's going to be published shortly, so you can look out for that, but I'll give some of the highlights. So I'm here to present about a roadmap for implementation of virtual care. I'll start with a bit of background. So pre-pandemic, there are a number of studies that showed that virtual care was really in an early stage of diffusion on the diffusion of innovation curve, with fairly low adoption rates in comparison to in-person in many places. As a result of COVID-19 and the need to socially distance or physically distance, many healthcare organizations had to rapidly shift from in-person services to virtual care. And now, while implementation science can support the effective implementation of virtual care and allow us to understand if an intervention has actually been implemented effectively, due to the urgency of the situation, this step was often, not the most crucial for many. And so, due to many years actually having implemented virtual care, I think over 10 years ago at our organization, we were able to leverage an approach rooted in implementation science to scale up virtual care from about 3,000 visits pre-pandemic to about 100,000 visits post-pandemic fairly quickly, resulting sort of demand in the sector to sort of access resources relating to implementation of virtual care led us to complete a study to develop an evidence-based implementation roadmap and framework to support not only our organization, but external healthcare organizations to further integrate virtual care within their services in a sort of ongoing sustainable way, as well as to really consider how they assess quality and outcomes. So the approach we used, the implementation roadmap consists of a toolkit which integrates theories and validated frameworks from implementation science, predominantly something called the Consolidated Framework for Implementation Research. This is an excellent framework that aggregates a number of actually many different implementation frameworks into one common taxonomy. It's quite vast, so there was a bit of a process in order to sort of pare it down for this particular context. We reviewed existing virtual care literature, and then we took our practical experience and evaluation from our organization. So the implementation roadmap mapped steps required onto the framework, the Consolidated Framework for Implementation Research. And this really looked at 5 key domains. So the characteristics of the intervention itself, external factors that might impact adoption of the or effectiveness of the implementation, internal and organizational factors, as well as the characteristics of people involved in both delivering and adopting the intervention. And finally, the process of implementing the intervention. So considering factors like planning, engaging, executing, and evaluating. So you'll see here, there's a brief summary of both the framework, which sort of includes all of these factors. So the intervention, some of the external and internal considerations, as well as some of the values and considerations that individuals might need to factor in as they implement virtual care. And then we also developed a process sort of map, which includes key steps under planning, engaging, executing, and reflecting and evaluating. And you'll see some red check marks. This, so this predated the pandemic, but as we entered the pandemic, we really needed to look at what people should consider in sort of a rapid implementation consideration. And so those are some of the key considerations. I'm looking at my time and I don't have time to go into each one, but as I've mentioned, this will be something that will be published soon, and we'll have a lot more in-depth description around each of these key constructs and how you might consider them within your implementation. So I will stop there because I noticed I'm at 5 minutes, but happy to connect with others if you have questions after in the chat, or not in the chat, but in the app, I think.
Right on time, Eva. Thank you so much. We don't have an opportunity for questions, but please make sure you connect with Eva on the virtual platform afterwards. Thank you so much, Eva. Next, I would like to pass things over to Don Burke from SEVAS to present. Hi, Don.
Hi. Thank you so much. So I'm an intensivist, which means a critical care specialist in British Columbia. And I want to give you a bit of background as to why we developed ROSE in the first place. In smaller community hospitals throughout British Columbia and basically all of Canada, docs are often unprepared for a critical illness when a really sick patient shows up. They have fewer resources and really no support or backup. And the result is poor outcomes for patients, get physician burnout, so they leave their communities, and a much bigger expense for healthcare, because to transport patients out to another facility costs a lot of money, and also to try to recruit a new physician and set them up is a big expense to healthcare. So we needed a solution, and it's now we call it ROSE, like the flower. We started off as a pilot study called CODI several years ago, and we collected a lot of data over 1 year. We wanted to see if it would work. And we also got continued feedback from all the physician users, and there were many. It worked. It looked like it worked on all the different levels that we were assessing. We've been constantly redesigning it and updating it based upon physician feedback. Almost like 95% of the changes have been from physician feedback. So basically it's an app for physicians by physicians. It's like a rubber hits the road type of a platform. The features of ROSE is that it's 24/7. 365 a year. There are no breaks in the service whatsoever at any time, always available immediately. There's no phone numbers required or links or passwords or pagers. It's one touch on the app, and it's on your cellular phone. So it's a very mobile and very fast, and you get an immediate connection to a specialist. It's fully encrypted, so you can transmit not only the information that you're discussing, but lab data, ECGs, imaging, ultrasounds, things like that through the app. It also has a device for variable bandwidth. We've tried other apps in the past before we developed this. And if you're in an area where you have a weak Wi-Fi or cellular signal, the signal would get choppy. And sometimes the whole audio or video would just freeze up. Well, it doesn't do that with ROSE. Was also able to dictate right into the app any pearls of wisdom or guidelines or little recipes for success for the physicians, or just a consultation, and they can print that right from the app to the patient's chart, or keep it on their phone with a little hashtag so they can refer to it later if they ever have a problem like this again. So they have like a roadmap. And they also called it an intensivist in your pocket. And that is because all of the scrubs that we have a little breast pocket or a chest pocket, and they can put the phone in and have the camera facing out. So everything they see and hear, we can see and hear. We can see the patient, the family, any support staff around, the imaging, the monitor, so we can see exactly what's going on. We can walk them through procedures. We can see their hands because we're basically sitting in their pocket. So if they're doing a procedure they're uncomfortable with, we can walk them through it. The result is that we have better patient outcomes and way better support and education. This is especially important for residents and new physicians. And therefore, it increases the quality of the care they provide. It also allows physicians to remain in their communities and not have burnout. And it helps also with recruitment and retention of new physicians. And also, it really reduced costs. So fewer transfers out, and also less in terms of trying to recruit new physicians who've left. I was actually just working in Ukraine in an area, it was kind of a regional hospital just outside the combat zone. And we had very iffy Wi-Fi and cellular signal, and yet it worked fine. It worked beautifully. The other thing is also is if you have a trouble, like say, for instance, they called me about a patient, I'm not quite sure about how to answer it. I can bring another specialist into the call instantly. So now this rural physician has two specialists on their screen. The other thing about it is that specialist can be anywhere in the world, and that physician or resident can be anywhere in the world. So the idea behind ROSE is basically it's immediate support for docs and their patients. It's education and training at the bedside on the fly, better outcomes for patients, and much reduced healthcare costs. The old saying of you feed a person a fish, you feed them for a day, or you teach them how to fish and you feed them for their lives. We want to teach people how to fish so that they feel more comfortable at the job, they have better outcomes. And the other thing is also it's much better for communities because patients get to stay in their own communities and their family support is so important. So basically that's ROSE in a nutshell.
Thank you so much, Don. Excellent presentation. Unfortunately, we don't have time for any questions, but if folks in the virtual audience do have some, please make sure you connect with Don afterwards. Thank you so much. Great. Next to the virtual stage, we would like to welcome Jeanette Rual from Women's College Hospital Institute for Health Systems Solutions and Virtual Care.
Thank you, Carina.
Hi, Jeanette. Thanks.
Good morning, everyone. So I'm happy to present on behalf of my CNDHE framework development team, our poster titled Co-Creating a Pan-Canadian Framework for Digital Health Evaluation, Lessons Learned. So what's CNDHE? So CNDHE actually stands for the Canadian Network for Digital Health Evaluation. And this established group really was the start of the framework. So a federal, provincial, territorial table convened and basically identified a need to create a national strategy to build capacity for digital health evaluation in Canada. And this also included developing a pan-Canadian framework. This group is actually in its third year of a funding initiative through Health Canada. Basically, it was just recognizing that with the pandemic, there was this rapid and massive upscaling or uptake of digital health technologies and virtual care solutions. However, much of this digital innovation was occurring in silos within different health systems of delivery. So there was this idea to have different jurisdictions and stakeholders at different levels come together around a single framework, open up opportunities for shared learning, shared experiences in digital health evaluation, and of course, collaboration. So on our poster, not all the work, I'm not going to talk about all the work that actually took place in developing this framework. Instead, I'm going to focus mostly on the co-creation collaborative process. And we basically conducted 90-minute virtual sessions with macro, meso, and micro level stakeholders. We also had ad hoc sessions with digital health teams and other partner organizations just to get their feedback. Throughout this process, sort of as a team, the core working team, we had post-collaborative sessions and team briefings to identify some of the challenges and lessons learned from this process. And we identified sort of like two streams of like lessons learned. So with respect to building a PAN-CAN framework, we learned how different provinces and territories prioritize different things. As well, different provinces and territories were developing their own frameworks. And we also uncovered sort of what are the certain conditions that are necessary to further guide and promote and sharing widely this pan-Canadian framework. Some of the key takeaways of building the framework included how equity was an important construct to be evaluated, should be prioritized and embedded. So initially we built the framework, or we had the idea of building a framework around the quadruple aim, but the change that we've made is that we've actually built it on the quintuple aim, which includes the equity piece. We also discovered that the framework is quite relevant, even though it was a big ask to think that a framework could be adapted to across different provinces and territories, but that it was relevant and had value to broad stakeholders, whether it was to inform policy or if it was to evaluate smaller scale projects. However, there really was this need to show exactly how the framework can be adapted in the different contexts, how it can be adapted to other frameworks, and how to build capacity evaluation teams across the different jurisdictions. So in order to promote sort of uptake and use of the framework for different users, it really should be comprehensive but pragmatic. In the process of this co-creation and collaborative feedback approach, some of the key takeaways we got were that it really was a complex and challenging topic to define conceptually. And so having collaborative input really strengthened the outputs that we had envisioned, really helped us identify the priority evaluation questions that we had for stakeholders. As well, we learned in the space that digital health innovation and research develops quite rapidly. And so we made sure to embed sort of cycles of reviews and updates as new information comes to light or is shared. And it really was challenging to engage with different stakeholders at different levels across Canada. But luckily, because, well, not luckily with the pandemic, most people were tuned into Zoom and Teams. So that really allowed us to have a broader reach across Canada to all the folks involved in the digital health space. So with this work, it really just met a timely opportunity to encourage impact assessment of digital tools on the Quadruple Aims and really foster shared learning across the different provinces. So using this collaborative and co-creation approach really sort of strengthened decision as well as the vision for the final outputs of the framework. So I would say that the next steps, or where we are right now, is we're currently in the process of developing a toolkit, which is really meant to guide users of the framework on how they can apply it within their different jurisdictions, how they can apply it to the different tools in order to sort of build that capacity for digital health. And we're looking at, making sure we reach people from little experience to people who are very well seasoned in evaluation. So in the development of this toolkit, we really are going to use a lot of the work that came out of the collaborative feedback sessions. And I am nearing the end, so I'll end there. Happy to connect with anybody outside of this session.
Thanks so much, Jeanette. Excellent presentation. There's just one question. Is the framework available to share with others?
Yes, there is a link at the very top underneath the Weave logo there that has a link to the report there if they could take a look. But I can also share it in the chat if you want to move on to the next presentation. Yeah, that
would be great. Thank you so much. All right. Let's keep on moving with our next presenter, Melissa Frew with Healthcare Human Factors. Welcome, Melissa.
Thank you. Thank you for being here, everyone, today, and for the opportunity to present this work. This design research project was conducted in early 2021 during the height of the third wave of the pandemic lockdown in Toronto. So as we've heard here today, virtual care has been brought into the spotlight during COVID-19, and we wanted to focus on the experience of virtual care and wondered what might come next. What was the next step? So we asked the question, what is the right level of virtual care in a primary care setting? And that will best support the patient-provider relationship and continuity of care experience. We wanted to understand how our future healthcare system might find a balance for virtual care and in-person care that would support the critical patient-provider relationship. We were inspired by strategic foresight methodologies and approaches to system design because we wanted to consider what could be in order to understand how to get there. Our goal was to work collaboratively alongside primary care physicians and patient partners. However, the reality of the ongoing pandemic lockdowns was that this work was completed much more asynchronously, and we needed to find creative solutions to ensure patient and physician voices were not only part of the research, but drivers of the solution. So we used creative survey techniques and asynchronous activities in lieu of in-person co-design sessions and conducted interviews and informal one-on-one conversations. The data gathered was then synthesized with additional secondary research, including literature review, government policy review, and environment scanning. We looked to other sectors such as international healthcare systems and local education systems to identify best practices in virtual experiences and find inspiration to inform the development of a future model of care. Key factors and systemic criteria that could support implementation of the model were also identified, and we then socialized the model through formal presentations and social media to gather further feedback. So what did we learn? Well, we heard of challenges with usability and the lack of consistent platforms. Both patients and providers noted the impact of a lack of access to devices, internet connectivity issues, and technology skills. And there remained ongoing concerns over data privacy and the vulnerability of accessing care, not just in terms of the virtual space, but also the physical space that it was accessed from. Some of the patients noted a discomfort in accessing virtual care in close proximity to family members and in public spaces. Above all, we heard about the mismatch between providers faced with policies that impose time-limited appointments and the burden of ever-increasing patient populations versus the desire of patients to be heard, which equated to time spent and included in their care planning and decision-making. We also heard about some successes. So virtual care afforded delivery and access to care far beyond what might have been available in many locations. There were savings in both time and money and a reduction in the inconvenience of appointments. And for some, accessibility and equity was improved. The proposed model aimed to capitalize on these wins and explore how to further enhance these opportunities while solving for the identified challenges. The digitally supported care space model illustrates ways in which technology can support interactions across a spectrum of care delivery, while also supporting patient inclusion and self-management. Technology can reduce burdens placed on providers by moving away from the concept of isolated moments of virtual care and towards a broader concept of fluid and ongoing digitally supported care and removing the pressure of time-limited care. So to support such a model, government and funding policies will need to support multimodal virtual care delivery permanently, and digital health innovations will need to support improved usability and access through implementation of established usability norms, consistent interface design criteria, and established accessibility standards. Lastly, our healthcare system will need to consider how it will support those for whom digital access is a barrier, and providers will need to be supported in creating a care space, whether that be virtual or in person. Thanks for listening. That's the end for me, but if you'd like to learn more, you can use the QR code on the poster to explore the interactive PDF of the model.
Thanks, Melissa. That's great. So finally, we're going to move over to our final e-poster presentation of the morning. Nadia Green, PhD student, with the University of Alberta. Welcome, Nadia.
Hi, thank you for having me. And hi, everyone. Thank you all for joining us. My name is Nadia Green, and I'll be presenting on improving Indigenous people's health through the use of digital health technologies. I just wanted to start off with identifying where I come from. And so I'm First Nations from Barons River First Nation in Manitoba. As well, I just wanted to note that June is National Indigenous History Month. So I'm happy to be presenting to you today. So in December 2018, my father, Vincent George Green, passed away. His cause of death was listed as cancer. However, I believe other factors contributed to his death. We hear too often the inequities that exist between Indigenous people and non-Indigenous people here in Canada. And it saddens me to think that my father is now one of the statistics who have succumbed to these inequities. But despite this tragedy in my life, my father's death has been the catalyst for the path that I am on today to improve the health of Indigenous people in Canada. Digital health technologies such as remote presence technologies, artificial intelligence, mobile health technologies, and others are becoming a popular means for providing virtual care services to Indigenous communities located great distances from urban centers. However, little is known at this time about the impact of digital health technologies and the care experiences of Indigenous people, as well as their healthcare providers. Shedding light on these experiences will help determine what care gaps exist and areas for improvement. And so the purpose of my study is to provide a deeper understanding of Indigenous peoples and healthcare providers' perspectives, as well as their experiences of care in a digital health context. And so some of the methods that I am considering using for my research involve involve two stages. The first being surveys, as well as the use of Indigenous research methods. And so the framework that I've chosen to help guide my research is the 6 R's Indigenous framework. And so this involves the use of respect, relationship, representation, responsibility, relevance, and reciprocity to help garner information related to care experiences of Indigenous people. One of the other methods that I'm hoping to use is digital storytelling, which is an arts-based research method that involves the development of a short video capturing the essence of participants' shared experiences. And so this is most relevant for Indigenous populations because it helps them to share in ways that are considered Indigenous ways of knowing. So I'm hoping to have this research started within the next year and completed within the next 2 to 3 years. And I will be partnering with a few Indigenous communities in Manitoba. And hopefully the relationship building process will lead to a long-term partnerships. And so some of the anticipated outcomes that I hope that my research will provide is to improve the overall health of Indigenous people here in Canada, to improve their overall health outcomes with respect to digital health, and to inform future research, as well as to serve to inform nursing education, practice, and policy relevant to Indigenous peoples' access to care and the use of digital health technologies in their care. And that's it for my presentation. Thank you.
Thank you so much, Nadia, for that excellent presentation and sharing with us this morning, and to all of the e-poster presentations. It's now a very exciting time to officially open the eHealth 2022 conference. So I would like to direct you all to please close this session and move over to the opening remarks and keynote accessed in the agenda tab in the virtual event platform. See you all there. Take care. Thanks.